Okay, everyone, welcome to Congenital Heart Hour. My name is Salim Jivanji. This is going to be a series of meetings across the next few Thursdays and through the year, and we'll be discussing interesting and perhaps controversial congenital heart disease cases. If possible, we'll try and also have an insight into cardiac catheterization and also congenital cardiac surgery. We'll have presentations from Hay, Liverpool Heart and Chest Hospital, but also other respected and well-renowned centers and individuals across the UK, Europe, and internationally. Before I introduce today's talk, next week we have a slight gap at the moment because we've just moved a few talks around, but we'll probably have an international speaker coming on for next Thursday, which I will update either towards the end of the talk or as a separate email. And we'll be happy for you to join either physically or virtually. Today, our talk has been sponsored by BVM, so we'd like to thank our sponsors as usual. During the talk, if you have any questions, please place it at the chat and we'll address it at the end of the talk. Today, we have Dr. Caroline Jones. She's our lead of service at Hay Hospital, and she's also a fetal cardiologist. So this is a big honor for us to have her on the meeting, and she will be talking about fetal assessment of hypoplastic left heart syndrome. Thank you.
Thanks, Salim, for the introduction. So just as an overview about what I'm going to talk about in the next 45 minutes, clearly we've got quite a broad audience for this session. So I'm going to do some sort of introductory slides, just talking about how we screen for congenital heart disease in the UK and the screening programme, a couple of slides about the fetal circulation, how we make the diagnosis of hypoplastic left heart syndrome before birth. Once we've seen that fetus, how we might risk stratify to think what their postnatal course might be. I'm going to talk about counselling and discussing options antenatally and formulating a perinatal management plan. And then we're just going to review some of the evidence relating to outcomes following a fetal diagnosis of hypoplastic left heart syndrome. So in terms of how we pick up the vast majority of congenital heart disease prenatally, it's due to the antenatal screening programme, which is run by the Fetal Anomaly Screening Programme. And it's a composite of a number of different assessments, obviously not just including the heart, but multiple other body systems that are assessed at the scan between 18 and 20 plus 6 weeks. In terms of looking at the fetal heart, the sonographers have 5 views to complete, which are analogous to many of the views that we see on a postnatal echocardiogram. So the first view down here at the top of the fetal abdomen, looking for the situs view, as we would do in a sequential scan postnatally. So looking particularly at left and right is important, working out which way the baby's lying, establishing that the fetal stomach is on the left, and the position of the aorta and IVC in the fetal abdomen. Moving up to a traditional 4-chamber view, and we'll look at some of those views in a moment. And the next view is assessing the left ventricular outflow tract and the aorta as it comes from the left ventricle. Moving up towards the fetal head, you can then see the right ventricular outflow tract, which crosses over the left ventricular outflow tract and branches into the pulmonary arteries and the ductus arteriosus. And the final view that's been introduced lastly, maybe around 10 years ago now, the 3-vessel and trachea view, looking at the pulmonary artery at the front, which becomes the duct and moves in a straight line towards the fetal spine. And particularly, we're interested in looking at the aorta and its transverse portion, calibre and blood flow through there. And we can see the right-sided SVC and the position of the trachea. So most patients we see prenatally with hypoplastic left heart syndrome will have been judged to have an abnormal 4-chamber view at their 20-week scan and will be referred on to a fetal cardiologist for further assessment. The other group of ladies who we will see in the antenatal period are those who have an increased risk of congenital heart disease in the baby, and that may be due to risk factors in the fetus or maybe risk factors in the mother or in the family. So we do pick up some hypoplastic left heart syndrome and single ventricle conditions, particularly in fetuses who have an increased nuchal translucency. So this is a measurement that the sonographers make early at the 12-week scan. And we know that looking at this measurement, it is a predictor for genetic and particularly chromosomal abnormalities, but it's also a predictor for congenital heart disease. So this is taken from the BCCA fetal cardiology standards, which were updated fairly recently, just looking at the nuchal translucency measurement at 12 weeks here and the risk of congenital heart disease in the fetus. So we can see the thicker the measurement, the more likely we are to pick up congenital heart disease. So we will be screening these patients early to look for problems. The other group of people we see, and I think it's important to talk about, particularly with hypoplastic left heart syndrome, is where there's a family history of congenital heart disease, be that in the mother, the father, or a sibling. We know that the risk of recurrence is slightly higher when there's obstructed left-sided lesions in a previous child or a previous fetus. And some studies have suggested this may be up to 8% in where there's been a previous fetus or child affected by hypoplastic left heart syndrome. We certainly have seen families where sadly they've had 2 affected children with hypoplastic left heart syndrome, or particularly where there may be other people in the family with a bicuspid aortic valve. So it's something that is worth screening for. So in any lady where there has been a previous pregnancy or child with hypoplastic left heart syndrome, again, we would make an early assessment between 14 and 16 weeks because of the risk of recurrence. Often, gladly, this is for reassurance, but occasionally we do find a recurrence, which can be particularly, obviously, upsetting. So in terms of the way the fetal heart works, just a reminder really that in the normal fetal heart, things work very differently. So in terms of the blue blood returning here, the right heart is predominantly the systemic pump. So the blue blood returning via the SVC and IVC here is pumped via the right ventricle in fetal life through the pulmonary artery, through the ductus, and down to the aorta. So the majority of the fetal body is receiving deoxygenated blood. The oxygenated blood received by the umbilical vein comes up through the ductus venosus, and there's a complex streaming effect with the eustachian valve and the foramen, which means that the oxygenated blood is preferentially streamed through the foramen ovale into the left heart, and the oxygenated blood is supplying the upper half and particularly the fetal brain. So the fetal brain is usually supplied by oxygenated blood. And obviously, to be aware in the fetus with hypoplastic left heart syndrome, this is going to be very different, and the fetal brain is not going to be supplied in the same way, which is why we can see that the fetal brain develops quite differently with hypoplastic left heart syndrome, and why we can see differences on MR scan, and partly why we can see differences in neurodevelopment in our children with hypoplastic left heart syndrome. So this is this complex streaming that happens at the foramen and is related to the eustachian valve, again, which means that the blue blood from the IVC is preferentially streamed into the right atrium and systemic right ventricle, and the oxygenated blood is returned into the left heart to perfuse the fetal brain. So in terms of how we perform a fetal echo, the ultrasound requirements are slightly more stringent. We've got increased demand for spatial and temporal resolution. We need very high frame rates. The fetal heart rate is somewhere usually between about 120 and 180 beats per minute. The baby's moving continually throughout the scan. We know that we can have certainly challenges depending on maternal BMI and fetal position, and we use a curved linear probe between 3 and 12 megahertz with a wider near field view. So in terms of the normal 4-chamber, this is obviously going to be the view where hypoplastic left heart syndrome is detected, and we'll usually in a scan try to get a view directly down. So we know that we can see the structures better that are perpendicular to our ultrasound beam. So here on a normal 4-chamber view, we can see the AV valves nicely. We're particularly looking for the offsetting of the AV valves. We can see the moderator band in the right ventricle. we may be able to nicely see the entrance here of pulmonary veins into the left atrium. And then we'll usually try and get a view with a more side-on view, so we can interrogate the interventricular septum nicely, see the interatrial septum. We can see the chambers here are nicely balanced. We can see good biventricular function. So in terms of the fetus with hypoplastic left heart syndrome, as postnatally, we can see different anatomies. So this is a fetus at 20 weeks with aortic atresia. It's important to note that when we see hypoplastic left heart syndrome antenatally, often the earlier they present, and if we look at some of them at 14 to 16 weeks, actually the left ventricle can look quite large. So you can see the size of the left ventricle in this fetus is actually perhaps reaching down to the apex. But you can see that the interventricular septum is very bright. So this is endocardial fibroelastosis developing in the left ventricle. We can see some of that brightness on the mitral valve apparatus. You can see nice right ventricular function here. We've just put the colour Doppler on here, and this is usually what you see, that we've got a poorly contractile left ventricle, and we can't really see any blood going into the left heart. We can just see the blood moving through the right heart. You can see some pulmonary veins here coming back into the left atrium. Normally, always it's quite easy to confirm the diagnosis going up to the 3 vessel view. So this is the front of the fetal chest, this is the spine. As I say, we just have the pulmonary artery and pulmonary valve we can't see in this view becoming the duct, and the duct moves straight from front to back. So we can see the blue laminar flow through the duct, and then we can see a small vessel here. So this is the transverse arch, and we can see the reverse flow in the arch. So even at 14 to 16 weeks, when we see this view and we can clearly demonstrate that we've got all reverse flow in the aorta, even when we're looking at a good sized left ventricle, we know that this is going to progress and this ventricle will gradually shrink through gestation. So here's another couple of pictures of aortic atresia, very similar here at 20 weeks. Nice right ventricular function. We've got a sort of immobile, rigid looking left ventricle here. We can't see the mitral valve moving very well. Often with aortic atresia, mitral stenosis, you will see a little bit of mitral regurgitation if the valve is patent. Clearly the pressure in this chamber is huge because there's no way for the blood to get out. Again, you can see some brightness in this fetus here with some EFE developing. And this is the same fetus at 28 weeks. So you can see the right ventricle is now starting to wrap around the left ventricle, more analogous to what we see postnatally. A little bit of a smaller looking left ventricle here. So we can see the ventricle gradually shrink over time with aortic atresia during gestation. Let's click on to the next one. Here's a fetus with mitral atresia. Clearly a very different appearance in terms of the way the left ventricle looks. Important here, all the time when we're assessing before birth, we need to make sure we're in a really nice straight cut through the fetal chest. So it's important to make sure we've got a whole fetal rib we can see on both sides here, front of the fetal chest, here's the spine. Again, here's the dominant right ventricle. And with mitral atresia, we can just see a very sort of thin slit-like ventricle. Sometimes it's difficult to see the LV cavity at all. Can't see any AV valve moving on this side. See a sort of small left atrium here. And we can just see the pulmonary veins coming in here. I'm just going to talk a little bit about pulmonary veins and looking at patients with hypoplastic left heart prenatally. But perhaps on this fetal echo, we're already a bit concerned that these pulmonary veins look quite prominent and quite dilated. So in terms of when we look at pulmonary venous flow prenatally, It's probably our best predictor of assessing the intra-atrial communication. As we know, this is something that's going to be absolutely essential after delivery, because all the blood returning through the lungs is going to need to move into the right heart. Before birth, very little of the blood flow is being sent to the lungs. Perhaps about 8% is going through the lungs. The lungs aren't being used, the baby's not breathing. Clearly, we know there's going to be a huge change in pulmonary blood flow after birth. There's going to be a big rush of blood to the lungs, and all that pulmonary venous return is going to need to move from left atrium to right atrium to supply the body. So we're absolutely dependent on a good atrial communication. Sometimes we can see the size of the atrial communication prenatally. We can measure it, we can look at the blood flow through it, but really looking at the Doppler in the pulmonary veins is one of the best ways of assessing how that atrial communication is functioning. So in terms of Doppler of the pulmonary veins prenatally, we're particularly interested in looking at the forward flow through the pulmonary veins, but also reverse flow. So as we see increasing reverse flow and an increasing A wave here backwards into the pulmonary veins, that's a sign that the atrial communication is becoming restrictive. We know that assessing the atrial communication prenatally is important because we can predict which babies are going to come out extremely sick and which babies might need either immediate intervention, or sometimes where we might even consider referring them for fetal intervention if there's a real obstruction at the interatrial communication. So this is quite an old paper now from about 2005, but they found that the looking at the ratio of how much blood was going forwards to how much was going backwards was the strongest predictor of the need for decompression or atrial septostomy immediately after birth. So here's our same patient with mitral atresia, where we're just Dopplering one of the pulmonary veins here. We can see in this pulmonary vein Doppler, we've definitely got some reduction in the diastolic flow here in terms of what we would see normally, and we've got a small A wave. So we're concerned that there's some atrial restriction in this baby. Just looking at another case here. This is a baby with aortic atresia. Same again in terms of looking at the 3 vessel view. We can see a big duct and we can just see a tiny aorta here with the reverse flow. Sometimes we can get a nice sagittal view where we can see the duct. So we've got the right ventricle anteriorly, the duct coming out around here to descending aorta, and we can see the transverse portion of the aortic arch here with head and neck vessels and the blood going backwards, so retrograde perfusion from the duct. Doesn't like it when I click. I've got all these videos running. Same baby again with aortic atresia. So right atrium, right ventricle. Here's the left atrium. There's a very tiny LV cavity. Again, we can see very prominent pulmonary veins here, very dilated pulmonary veins. And if you look really closely, you can see actually a tight membrane across the foramen that's sort of blown up. So we've got restriction of this interatrial septum. And when we put the colour on, the pulmonary veins are extremely prominent. We can see all 4 of the pulmonary veins here return to the left atrium. And this is a very abnormal pulmonary vein Doppler in the fetus, where we're just seeing to and fro flow, really. So we know that this baby is going to be extremely sick after birth. This is the slide which crashes my presentation every time. So let's see. It's important to say when we're looking at imbalance, clearly the cases we've looked at so far, we've seen either mitral atresia or aortic atresia, but sometimes we might see aortic stenosis, critical aortic stenosis, or mitral stenosis. And it's particularly important to make sure in a square-on view. We know we can see imbalance quite frequently. So in this patient here, we can see that the LV is a bit smaller than the RV, but we can see a mitral valve, we can see an aortic valve, and though the LV is a bit more slender, we can see its apex forming. see if it'll show me the other. Here we go. Here's another 4-chamber view. Fetal spine, front of the chest. Again, we can see a full fetal rib here. So we know we're in a square on 4-chamber view. Tricuspid valve, we can see the mitral valve moving. And we can see that the apex does come down here. So a very slender left ventricle. And actually, both these fetuses had hypoplastic aortic arch or coarctation. So both of them had adequate left ventricles that maintained the systemic output postnatally, but it can be quite deceiving looking at the size of some of the left ventricles in this group of patients. So we've got to be particularly careful. Important to measure everything. Again, very similarly, there's Z scores available for fetal echo dimensions by gestation, so we can look at the size of the mitral and tricuspid valves, etc. So when we make the diagnosis of hypoplastic left heart syndrome or any antenatal single ventricle condition, how do we predict what happens postnatally? What are the areas of uncertainty? Are there risk factors that we can identify either with the pregnancy, with the anatomy, with the scan that might predict the postnatal outcome? So it's obviously important that we get a holistic picture of what's going on. It's obviously particularly important in terms of counselling and how you might approach a family if this was perhaps their second baby with hypoplastic left heart syndrome. Typically, the diagnosis is made around 20 weeks, but it may be that we're making the diagnosis early. And certainly, I have actually made a diagnosis of hypoplastic left heart syndrome at 39 weeks gestation, and she actually delivered the week after. So it was particularly challenging. It can be picked up later in pregnancy. We clearly need to ascertain whether there's other things going on with the baby, whether there's any extra cardiac involvement. We know that postnatal progress, we need all the other body organs to be working well to embark down the 3-stage palliation strategy to a Fontan circulation. And we know for a small amount of patients with hypoplastic left heart syndrome, so for perhaps 1 in 20 babies, there may be an underlying genetic or possibly chromosomal condition which is accompanying the hypoplastic left heart syndrome. So we would obviously talk about testing for that. So in terms of fetal counselling, it's very much a multidisciplinary team approach. We work very closely with our colleagues in fetal medicine, midwives, fetal cardiac nurses. We need to think about what further investigations we might need. Obviously, get a detailed scan with one of our fetal medicine colleagues to look for extra cardiac problems or anything else that maybe might point towards a genetic or chromosomal diagnosis. We'll generally talk through how the normal heart works initially with diagrams, and then we'll talk about the specific findings for their baby and what that will involve. We clearly talk through potentially what the palliative strategy and postnatal management would be. We do talk about looking for genetic or chromosomal abnormalities, which usually by the time the diagnosis is made is an amniocentesis test. So a needle into the fluid that's around the baby, has the baby's skin cells in. That test does carry a 1% risk of losing the baby, but some families will want that information to see if anything else is going on. We talk about options. I'll come on to that in the next slide in terms of continuing the pregnancy, opting for a termination of pregnancy or compassionate care after birth. And it's important to offer, we obviously see these families a couple of times throughout gestation, just looking at the left heart. We know things can change. We know atrial restriction can develop later on. So you'll all be familiar with this. We've talked a lot about hypoplastic left heart syndrome in Congenital Heart Hour in the last few weeks. So it's clearly outlining, trying to outline in sometimes what is quite a short amount of time, what a lifespan with hypoplastic left heart syndrome might or could involve, what the palliative surgical pathway looks like. We do make sure that we talk about neurodevelopmental outcomes, brain development, both in utero and the effect of bypass on the brain. We know that in our children surviving with hypoplastic left heart syndrome, we're going to see an increase in neurodevelopmental delay, attention deficit disorder or autistic spectrum disorders. We talk about growth, we talk about other things that might be going on with the baby, and then it's outlining the pathway that we see here at Alder Hey and what that might involve. And sometimes it's the practicalities of it. We know there might be an extremely long stay post Norwood, and sometimes some babies may be in hospital 4, 5, or even 6 months. We talk about the interstage period and the little hearts at home monitoring and what that involves. We particularly talk about vulnerability to infections, repeated hospital stays, feeding, NG tube, PEG tube, and all those things. And if we look, I'll talk a bit more about the evidence supporting this, but if we look at all comers following a fetal diagnosis, probably survival to 5 years is around 50%. And much of that mortality is in the first year, either post-surgery or in the interstage period, knowing that we may lose some babies pre-surgery or babies who may not be suitable for single ventricle palliation. I think it's important when we're talking to families, thinking about what might be important to them. I know certainly sometimes it's whether families feel they can cope with having a baby or a child with this level of medical need, intervention, time in hospital. Clearly, we present them with a lot of information, data, survival, morbidity, quality of life, neurodevelopmental outcome, but we know there's a lot of other impacts of having this diagnosis on the family, and it's really how long you've got in terms of a fetal counselling session to talk about financial burden, other big impacts on other siblings for families who may have 2 or 3 other children already. We know the amount of parents who actually have to give up work when they have a child with a single ventricle condition. And things change as well. So there's really quite a lot to talk through, and sometimes different things may matter in different ways to this particular family. Talking about risk is quite interesting, and it's interesting how different people will perceive risk differently. Sometimes you'll present a risk to a family and they may say, oh, that's a low chance, and other people will think that's a high chance. It's how we say it, how we talk about it. We probably don't get much training or education in how we talk about risk and how families understand risk. And actually, when we look at, when they did a study looking at hypoplastic left heart syndrome and those who were high risk and those who were standard risk, actually the family's choice in their decision making in continuing with the pregnancy or stopping actually didn't differ between the two groups. I think there's some point where actually becoming extremely high risk, where you're already presenting them with such a complex heart condition, perhaps doesn't give them that much information in terms of decision making. In terms of all fetal counselling, I think it's the families and parents' ability or how comfortable they are in dealing with uncertainty. Much as we can give them information, we know that for children undergoing a single ventricle palliation, there's some of them who do extremely well and have short hospital stays, who are in school running around and you don't know much wrong with them. And there's others who struggle at every single stage with long hospital stays, recurrent admissions, and a shortened lifespan. And can be extremely difficult to sort of cover that scope within a fetal counselling session. Certainly it can be quite difficult when there's some families who, no matter how long you go through it, they may say, well, maybe it will just get better. Maybe next time it will just be better. And clearly there's families who want to maintain that hope during pregnancy. And there's other things which can complicate. We know that we do see hypoplastic left heart syndrome in twin pregnancies, which can really make decision making much more complicated. In terms of the options following a diagnosis of hypoplastic left heart syndrome, we've obviously talked through the surgical palliative pathway. It's important to say that this is something that potentially even after birth may change. We know if the baby's born early or is born at a very small birth weight, it may be that actually we can't offer a surgical pathway. We've already talked in this in previous sessions about hybrid. Some families, it's becoming less and less of the case, but some families may want to choose compassionate care after birth. So they may decide that termination of pregnancy is not an option for them, but they wouldn't want to pursue active surgical palliation. We know that with hypoplastic left heart syndrome, without maintaining ductal patency, usually survival is a couple of days, perhaps maybe a week or a couple of weeks in some cases. We talk about termination of pregnancy as an option, and there's some changes in how that has to happen legally around 22 weeks. And we also discuss the chances of there being an underlying genetic or chromosomal abnormality, which may significantly impact on our ability to adopt a palliative surgical strategy postnatally. I put fetal intervention down at the bottom here. It's extremely rare that we actually manage to diagnose these babies at the right time to make fetal intervention an option, but it does come into play with some cases if there's restriction at the interatrial septum or if we're dealing with a case of critical aortic stenosis. So in terms of the current law around termination of pregnancy, this now changes actually at 21 plus 6 weeks, where legally a baby isn't allowed to be born alive. So prior to 21 and 6 days, which doesn't give us a lot of time in terms of the 20-week scan. So having your 20-week scan, being referred to fetal cardiology, making the diagnosis. Prior to 21 and 6 weeks, it's inducing labour and the baby being delivered. But at 21 and 6 days, by law, the baby isn't allowed to be born alive. So an extra procedure has to happen to stop the baby's heart from beating. For hypoplastic left heart syndrome, you would have an option of stopping the pregnancy beyond 21 and 6 days because it is a life-limiting condition. But there's obviously significant law around this, where 2 practitioners would need to sign that this was the appropriate, a reasonable course of action considering the severity of the heart disease. So in terms of communication during counselling, clearly we try to be impartial and non-directive. We try to not use jargon where possible. As I say, usually we'll run through how the normal heart works first to get an understanding of the severity of hypoplastic left heart syndrome. We really rely on having very good interpreters in many cases. We try to avoid using family members. You do have to constantly take verbal and non-verbal cues from the parents as to where they are. Certainly, we know some families will just burst into tears within a short amount of time of starting, and it's having to pause, having to stop, having to go through parts again. We need to understand how we talk about risk. We need to listen. We need to check the family's understanding. We need to give the family time to process. Certainly, at the first consultation, we know that probably a lot of what we say they're not actually going to remember. It's just trying to process actually the bad news more than anything else, and we may need to go through the whole thing again at a repeat visit. So sometimes we need to recognise this sort of grieving process, and being the breaker of bad news can sometimes be difficult, and you can sometimes be met with anger or aggression or grief, and everyone's reaction will be quite different. People don't always respond in the way you expect them to. And it's particularly important for us to reassure people that it's nothing they've done. In the vast majority of cases with hypoplastic left heart syndrome, we really still have quite a poor understanding of what causes it. Often in terms of studies looking at how families cope with decision making, I think it's particularly important to sort of validate their decision, whatever decision they make. Certainly, I think psychologically going forward, parents do better when you validate their decision and tell them that you support them with their decision either way. And we try to reassure them that the actual recurrence risk is quite low, but we would, as I say, offer early scanning to future pregnancies. As I briefly mentioned before, there's lots of people involved in this process. We're particularly dependent on our fetal cardiac specialist nurses and/or specialist midwives who sit in clinic with us. We work very closely with the fetal medicine consultants, obviously in liaison with the neonatal team in terms of the perinatal plan. And we may actually bring in other teams, particularly if there's genetic or extracardiac abnormalities. And certainly I know in Liverpool, there's really good collaboration with the palliative care team and parallel planning for some of these babies or families who may want to choose compassionate care after birth. So obviously following the diagnosis, there's a lot of work, particularly done by the fetal cardiac nurse specialists, about providing ongoing support. And that's further information, prenatal preparation in terms of what's going to happen after birth, particularly if they're going down the surgical palliative strategy, linking with other services, linking with palliative care, sometimes obviously offering bereavement support or offering support to families who have chosen to have a termination of pregnancy. It's important to assess things throughout gestation, so we'd usually see them at 20 weeks, 28 weeks, and then in later gestation to look at the interatrial septum and look for atrial restriction, to assess the tricuspid valve. It is unusual to see fetal compromise or high drops, as I say, particularly because the right ventricle is the systemic ventricle prenatally. It's important that we measure fetal growth. You know, if we know we've got a small baby with hypoplastic left heart syndrome, that might shift our counselling and what we'd expect postnatally. For the majority of cases, what we see at 20 weeks is the same as what we see at 32 and 34 weeks, we'd have to say, though in some cases things do change. And it allows us obviously to go through everything again, further counselling, talk about practicalities. Between different visits, there's obviously a shift in focus, and that may be towards surgical palliation, or it may be towards parallel planning and what's going to happen in terms of compassionate care and what the family might want after birth. So in terms of perinatal management planning for hypoplastic left heart syndrome, we would deliver them in a cardiology, either in the cardiology centre, so at St Mary's Hospital in Manchester, where there's ready access to the cardiologists, or in Liverpool at Liverpool Women's Hospital with an early transfer over to Alder Hey. I think there is a question if there's restriction in the atrial septum, and that can be a bit of a spectrum about how severe that looks, as to whether we may refer some babies to a centre where they can actually be delivered in the surgical centre, because we know there's going to be a high chance they're going to need immediate intervention. We're going to try and deliver them as close to term as possible. We'd always try and recommend a normal delivery if possible, though we'd have to say for a lot of our babies with significant congenital heart disease, they do have an increased risk of having an assisted delivery or caesarean section, probably because we're monitoring these in labour quite intensively. A standard advice: the baby's going to go to neonatal intensive care. They're going to be started on Prostin to keep the duct open. We're going to want to get these babies over quite early, because clearly we need to do a number of assessments, and we want to get the Norwood procedure timed right, usually in the first week for optimal results if the baby's a good weight and term gestation. So I'm just going to have a quick look at, I know I'm running out of time, at some of the data relating to outcomes following a fetal diagnosis. So this is probably the best this is a accumulation of data looking at, let's say if we had 100, and again, this is live births with hypoplastic left heart syndrome. So this is a composite of some of the BCCA data as well as some North American data. So if we look at 100 live births with hypoplastic left heart syndrome, 91 of them undergo a stage 1 Norwood procedure or stage 1 procedure of some sort. After that, 70 of them will be discharged home alive after stage 1. 61 will undergo a stage 2. After stage 2, 59 will be discharged home after the cavopulmonary shunt, with 55 patients undergoing the Fontan procedure and 54 patients being discharged after their Fontan procedure. So looking at 100 live births, we're looking at, and again, this data here is mostly from the Fontan registry, but we're looking about half of them alive 20 years after their Fontan procedure. So there does seem to be in the patients who undergo Fontan, that then once you're past Fontan, we're seeing good survival rates in the long term. So this is probably the biggest series in terms of looking at Fontan outcomes. This is from the Australian and New Zealand Fontan registry. But still, if we look at the numbers, I think there's something like 1,600 patients with a Fontan in this registry. Actually, only 193 of them have hypoplastic left heart syndrome. So we've got to be mindful that a lot of these patients have been lost down the palliative strategy a lot earlier on. This is from Boston. So again, in terms of trying to risk stratify, we know that we can see a big difference in hypoplastic left heart syndrome standard risk and hypoplastic left heart syndrome high risk in attrition, particularly in the first couple of years. A lot of these babies have atrial restriction or other risk factors, meaning that their outcomes are very different. And we know birth weight is a massive determinant of outcome. This is actually for all comers with congenital heart disease from the STS database, 2,000 neonates. And even birth weight Z scores slightly below average are independent risk factors for mortality and morbidity in infants undergoing cardiac surgery. So your birth weight is a massive determinant of how you do. And we know it's particularly important for us sort of fetal cardiologists, because we do sometimes tend to end up pulling these babies out a little bit earlier perhaps than we should do. So this is from the SVR trial, North American multi-center trial, which was designed to look at the Norwood procedure essentially. This is infants with 906 infants with hypoplastic left heart syndrome. Prenatal diagnosis is the darker line, no prenatal diagnosis, and this is the gestation at birth. And you can see we're just slightly shifting it a week or two earlier. But we know that even minor changes in gestation or birth weight are going to impact on things. So we really want to try and get as close to term as possible in terms of delivery for these babies. Again, this is the evidence around if you've got a restrictive interatrial septum. So this is looking at the strongest discriminators for severe neonatal illness and pulmonary vein Doppler. Again, they were using this time antegrade to retrograde of less than 2.7 or a larger pulmonary vein diameter predicted death or transplant in these babies. And similarly, looking at data from the intervention registry, whether you believe fetal cardiac intervention makes a difference for some of these babies. This is no fetal cardiac intervention in this column. This is babies who had fetal cardiac intervention, and this is alive at discharge. So a third of babies alive at discharge with no fetal cardiac intervention, and 44% with fetal cardiac intervention. So obviously that's guarded with the fact that there's a significant mortality associated with intervening before birth. I'm going to skip over that slide. So in terms of fetal cardiology, I'm kind of like hoping we're going to get some AI that we can actually predict the whole outcome here by putting in all the information. We need to ascertain the morphology, but we also need to think about the function and the physiology. We're dependent on working with our fetal medicine consultants to really bring the whole picture of what this might mean for life after birth. I haven't touched on it much today, but many centres are using fetal MR, particularly to look at brain development and pick out markers that are associated with poor neurodevelopmental outcome. Genetics, I'm sure, is going to continue to change year on year, and we're going to get much better information before birth, particularly with whole exome sequencing now available to many babies, particularly where we're seeing 2 congenital anomalies before birth. And again, a particular area of interest is looking at the maternal fetal environment and placental function and growth, and how we can modify these things to get the baby in the best condition after birth. So in summary, prenatal diagnosis for hypoplastic left heart syndrome rates remain very high. It's one of the conditions we have diagnosed very regularly, and it's rare that we see postnatal diagnosis. We know that a prenatal diagnosis improves your postnatal outcome. It's important that we really look at the anatomy and try and risk stratify as much as we can to pick out things where postnatal course might be difficult. We know that our counselling should be impartial and non-directive. We need to keep up to date with evidence, particularly so we know what the outcomes are both in our centre and internationally. And we'll continue to use an MDT approach to support parents and families through this difficult decision making and postnatal treatment pathway. I'll leave it there for today.
Thank you very much, Caroline. That was great, very comprehensive discussion. And I think went through it in a very detailed fashion. We've sort of gone in a reverse way. We've gone from adults, teenage to newborn to fetal. So we're going a bit backwards in terms of how our talks have arranged, but it was really great. Thank you very much. Does anyone on the audience got any questions? So I think I have one question. So from a fetal assessment point of view, we've seen quite a few interesting cases over the last few months, particularly ones with very restrictive interatal communications. We've seen various different counseling given to families in terms of what's going to happen. What, from your perspective, what are the most, I mean, the ones which are mild and the ones which are very severe are sort of relatively straightforward, but what's your biggest challenge in hypoplastic left heart when you're making the assessment and finally giving counseling? Which are the groups which you find the most difficult to talk about with the families?
I think from a diagnosis point of view, definitely it's assessing the atrial septum, which is most difficult, because despite, you know, working down at the Evelina, there's some of them who've had extremely abnormal pulmonary venous Dopplers, and you've basically assembled half the hospital in an operating room to perform emergency life-saving surgery or intervention on this baby, and the baby comes out with sort of saturations of 88 and screaming and looks absolutely fine, and everybody looks at the fetal cardiologist like, what are you thinking? So it is really hard to get it right, and I think sometimes you will have a lot of people assembled on a false sort of prediction. I am concerned that with some of them, you know, as I was saying the other day, we've certainly had some babies where we've been concerned about it, and then after birth they've just been so sick, and not having the ability to deliver them in-house is a worry. I don't know what Joyce thinks. I mean, it's the thing we agonise over a lot with.
Yeah, as Gordon puts it, sometimes it is nature pre-selecting. So
yeah.
It depends on, I suppose it depends on how much the parents want
Yeah.
to pursue at all costs or not.
Yeah. I think in reality, some of the most difficult ones to deal with are often the families who can't decide what they want to do, and that you have a long pregnancy where they're seeking different opinions, they're seeking international opinions, they're looking at stem cells, they're talking about the hybrid, their fetal intervention, they might stop, they might, and there's a lot of information seeking that can go on throughout the pregnancy. Certainly parents who make a decision early and have that decision validated, I think, cope with it better. But the patients the families who really agonize over their decision, you can see that struggle can sometimes go on throughout the whole pregnancy, which is difficult.
So I think in hypoplastic left heart, the involvement of the parents and in terms of what discussions take place are significant, because the timing is very, very important. And we've had some audience from countries like Kenya and India, which have asked, who are not present at the moment, but we've had one patient which was discussed with us over the last couple of weeks, where they had a hypoplastic left heart born, and they were trying to figure out how to manage the patient. But the amount of involvement which is required by the team, plus the multiple operations and the expenses are a factor. And probably we are very lucky in the UK. Well, we are lucky in the UK that we have this provided under the NHS, and all these decisions are sort of taken out of the expenses situation. So we've got a couple of questions from Letty, who used to work with us before, and her questions are sort of similar to each other. One is, can you see antenatally if the aortic valve is bicuspid or not? And if in a sibling, if a previous baby passed away with hypoplastic left heart, is there a need to do a postnatal echo to see if the aortic valve is bicuspid or not, if the fetal echo was normal?
Good questions. First question, we can't clearly see if it's bicuspid or not. Occasionally, at 20 or 28 weeks in a heart, I can see the trileaflet valve, but it's really pushing it. You wouldn't confidently. It would always require a postnatal assessment. Second question is quite difficult. Actually, the family who, I think one of the patients is Joyce's, who had 2 babies with hypoplastic left heart syndrome. When we scanned the 6-year-old, he's got a bicuspid aortic valve, and I think Dad's got a bicuspid aortic valve. I think probably the answer is yes. If there is a sibling with hypoplastic left heart syndrome, it is worth screening for bicuspid aortic valve in siblings. We tend to. So if there's, I think aortic stenosis is one of the indications where we would not just screen prenatally, we probably would do a couple of visits. I think there is a suggestion that a 32-week plus scan is helpful to look again for aortic stenosis, but I think there is some case to look at siblings for bicuspid aortic valve, yes.
Cool. Any questions in the audience here? Sophia?
I'd probably say that slide you had with all the kind of different factors in fetal cardiology and how it's evolving. When I presented on fetal intervention before, and there might be some cases where, you know, some people have the argument of just because you can't, you shouldn't, or should you? So fetal intervention or early like exit procedures or whatever you want to call them, there's an argument for just because you could, do you, or do we get more and more data and find more and more about? Because even now we might say, well, deliver a baby, Evelina, they'll have a, like you'll say, you might not get it quite right, or you do the procedure immediate birth, and then that baby still has a really poor outcome, and you've done all that. But I think there's still a role for challenging ourselves and what we do. I am going to say that because I like the specialty, but all the different factors you had, like the genetics, the in vitro environment, in it, there's the mum who's really important, there's the whole family, and there's a baby, so everything you do has an extra layer of ethics and worrying about any decision you make. But on the flip side, if parents, which we face, postnatally want to do everything, then there's opportunities to push yourselves a little bit and get that data and see, and then that could then lead to more data for everybody to make things more fair, just, all those words, beneficent for everyone, etc. So I don't think we're quite fully there with everything we do, but I think it's a brilliant specialty that's evolving, and there's lessons learning at every point. So I know you said you were at Evelyn probably maybe 10 years ago, and they're doing that. We've still not got quite the answer. Sorry, I shouldn't put in the years. We've probably still not quite got the full answer of what's the exact right thing for each case. But I think there's loads of opportunities, and I think being honest with families is good, but really hard when they've only just started doing that. It's very hard to. Caroline makes it sound easy, Joyce makes it sound easy, but I have shakes there. I'm trying to talk to families and put forward so much information in a short time with people of all different types of understanding or viewpoints, or all their personal background comes into it as well. So really difficult, but really interesting and important. That's what I'd say.
I just add about, I think you're alluding to sort of fetal interventions and whatnot. I think the problem with fetal intervention that I can see is that it's not common practice, and because you don't do it frequently enough to get the numbers to tell parents what the potential good outcomes could be, it's difficult. And at the start of any intervention procedure, if you were to sort of decide to do something, you would always do on the more serious end or the more severe end of the spectrum, and they might not necessarily get the better outcome. But you would never consider doing a new procedure in fetal life on a relatively sort of minor or sort of mild sort of condition. So where do you go? And although I think Evelina does offer fetal balloon aortic valve stenosis, but the problem is that they don't have much experience. And then should we provide them with more experience? But how can you convince parents to send their there are fetuses there if you can't be sure that the outcome will be good?
I think it's pushing boundaries without being experimental because it is people's lives at the end of the day. But the whole question of like better measures and prediction is probably, and then actually looking at our data more and more. Like today, I've written down a meeting with our name and would I go back and look at this Manchester Bay? Would I go back and look at their fetal imaging? It's just trying to learn all the time, I think, and it's probably the same for people doing postnatal cross-sectional imaging. Probably the same thing.
Like I think last week we discussed at our kaki about the fetuses with a restricted atrial communication. So one that we discussed at the kaki survived for 14-20 days, where I thought there was no hole in the atrial communication. And another one that initially I thought there wasn't a hole, but at 34 weeks, there was a better, it was a sizable hole, 2-3 millimeters. And that one crashed soon after birth. So, you expect the one with no hole to crash soon after birth and the one with, how did that happen?
That's all those little factors that data on.
Okay, I think we're going to wrap this up. Thank you very much. Thank you to Caroline Jones for giving this really wonderful talk. Thank you to sponsors BVM for today. Please provide us some feedback. There's a QR code on your screen right now. If you can please just give us a short feedback. It'll take you a couple of minutes to do that. It's really helpful for us to develop these sessions. And finally, next week, I haven't got confirmation yet, but we should have hopefully an international speaker, which we will let you know in the next few days. Thank you very much.